Okay, so we've just spent some time talking about the cholinergic synapse. And we're going to soon get into the adrenergic synapse. But just some last minute kinds of things before we move forward. So we talked cholinergic systems, and we realized cholinergic systems is a vague term, and we need to know more. Which cholinergic systems? Autonomic ones? Somatic ones? Are we in the ganglia? Are we in the target tissue? What's going on? So in order for those cholinergic systems to function, they have to use receptors. And so we know about nicotinic versus muscarinic. We know that the nicotinic in the ANS is found in ganglia. Right? We know that nicotinic receptors in the somatic nervous system are found in skeletal muscle. We know that muscarinic receptors in the parasympathetic nervous system, right, are found in the target tissues. So now we're putting some qualifying statements to these receptors. Where are the receptors for these cholinergic systems? Right? So here are the receptors. And just very briefly, the nicotinic receptor, as you know, is a ligand-gated ion channel. And so if you look at the structure of this receptor, just from a cartoon sketch here in the drawing, you see that we have this pentameric structure, right? And we've got 5 subunits coming together in such a way that a gate forms in the intramembrane area. Right? You see down here this gate. And this gate will open or close depending on whether or not acetylcholine has bound to the receptor. And so what's interesting is when acetylcholine binds to the receptor, the gate opens, and there's actually a fluid in here. You know, this is a watery area. And so the ion, sodium, can enter through this watery area into the cell. Or potassium ions may leave. Remember, this was called a non-selective cation channel, right? Pentameric structure. Here's a side profile up here on the upper left, right? So this is if you were a phospholipid in the membrane, like standing shoulder to shoulder with the receptor. This is how it would look. And here's how it would look if you're sodium and you're trying to get in from the outside, right? You see this opening that allows you in. The sodium travels into the water, brings water with it. And potassium leaves with water, so there's no net exchange, no net increase in the water. But this opens up a hydrophilic area within the hydrophobic membrane to which the charged ion can move. Right, so some of you on the exam wrote, for the first question, an example of ligand-gated ion channel, you wrote the sodium-potassium ATPase. That's not a correct answer. The sodium-potassium ATPase is a transport protein found in muscle cells of the heart, for example. And what is its job? It's ATPase. It burns ATP to move sodium across its concentration gradient back out, and to move potassium against its concentration gradient back in. So it grabs hold and it reestablishes the gradient. It's not a ligand-gated channel. And that's an important thing to know, because when you get to cardio drugs and you talk about heart failure, you're going to hear about the sodium-potassium ATPase pump as a drug target. You want to know that that's a different thing than the nicotinic acetylcholine receptor, which doesn't really require energy, right? The drug binds, the channel opens, and the ions just move down their concentration gradient. There's no ATP needed. Is that clear? Because there was quite a few people who wrote sodium-potassium ATPase, which was, I felt I needed to clarify that. Very different than a muscarinic receptor, right? So muscarinic receptors are where? They're over here in the targets of the parasympathetic nervous system. And so these are 7 transmembrane spanning G-protein coupled receptors. And so, again, there are 3 major ones in pharmacology we talk about in intro. M1, M2, and M3. M1 we see as mostly presynaptic. M3 we see as postsynaptic on target tissues, such as the bladder, such as the smooth muscle that make up the blood vessels, such as the smooth muscle of the bronchi, such as the smooth muscle within various glands. Okay? M2 we mostly see in the heart. Right? So one of the things you want to keep straight is where are these three? M1, M2, M3. Where do we find them? The next thing is how are they coupled? And so M1 and M3 are GQ coupled, which means that they activate the lipase, right? Phospholipase C, so you get second messengers like IP3, DAG. The C stands for calcium, the C stands for contraction, right? So that pathway activates calcium signaling. The GI pathway linked to M2 inhibits adrenalyl cyclase and regulates the potassium channel, allowing the heart to slow down. Okay, so those are the big three that we discuss in intro. And so if you're to summarize the various types of cholineceptors, right? And cholineceptor is just a vague word, a receptor for acetylcholine. Well, what does that mean? There are different kinds. Are you talking about M1 or M2 or M3? Are you talking about the nicotinic neuronal? Are you talking about the muscle type? What are you talking about? Right? So you have to pay attention to these different subtypes because sometimes you may be asked to explain, what is the consequence of activating the M2 receptor? Or what is the consequence of inhibiting the nicotinic neuronal receptor in ganglia? Right? So keep them straight based on their organization. So this table seems kind of busy, so let's not think of it as busy, but let's think of it as being organized by things we've already talked about, like different types of receptors, like M1, M2, or M3. Notice there are M4 and M5 receptors as well in the body. And this table is now getting kind of old, 2001 reference, right? We now know that the M4 and the M5 receptors are found in the CNS, and there will be adverse effects in the CNS associated with blocking them. So you may have heard this phrase, anticholinergic effects. You can have anticholinergic effects in the ANS, which we'll talk about here. You can have anticholinergic effects in the CNS, which we won't focus on, but which you will learn about in courses on the CNS. So for our purposes, we're going to not focus on M4 and M5, but I would like you to know that they're there in the body, that they exist, right? And if you hear about them in the future, you don't be shocked, right? But M1, M2, M3 are the receptors we focus on thus far. We're not going to talk about their other names. Don't worry about that. The location we've already mentioned for most of these. We've already talked about the fact they're G-protein coupled receptors, and we've already talked about the second messengers to which we see changes associated with them. Right? So there's nothing really new here. If you go down to the bottom part of the table, you see the two types of nicotinic receptors. The muscle type is also known as an end plate receptor on the surface of the skeletal muscle. So this term end plate is an old term for skeletal muscle surface. That's the end plate. Sometimes we call this the neuromuscular junction, but again, somatic nervous system, one fiber all the way to the skeletal muscle. The neuronal type is sometimes also called the ganglion receptor. And if we look at these receptors, we see that they both have pentameric structures. The traditional is the two alpha subunits, the beta, the gamma, and the delta. Right, so the muscle type. But we also have the neuronal type, which is only made up of alphas and betas. So do you see, we give them different designations because the way they're arranged in space is not exact, but the responses that they mediate are similar, movement of ions. Okay? So I'm not going to ask you which is made up of two alphas, a beta, gamma, and a delta, which is only made up of alpha and betas. I'm not going to do that. But this is why they're separate receptors, and this is why they have unique affinities for their own ligands. Okay, so again, if we're looking at the neuromuscular junction, right here we've got that one fiber leaving the CNS, forming a synapse here on the skeletal muscle end plate, releasing acetylcholine binding to those nicotinic receptors and a fast contraction. Now, a little bit about the organization of the sympathetic nervous system, and we've done this to some degree in the last lecture. Remember, we can look at this autonomic nervous system as two big divisions, sympa and parasympathetic, and that those terms were actually originally anatomical terms, right? Anatomy came up with these terms based on where the ganglia were. Right, so sympathetic ganglia were near the spinal cord or on the side of. And by the way, these ganglia tend to be located by the vertebrae of the thoracic and the lumbar regions, right, of the spinal cord. So if you were to look at the next slide, maybe this is shown a little better. Right, if we look at the spinal cord and we see that the first fibers coming into ganglia on the side of the spinal cord into the sympathetic ganglia, the first fibers are coming out of thoracic down to L2. Right, so this used to be called the thoracic lumbar system or the thoracolumbar system. It's a synonym for the sympathetic nervous system. So your book may use this term, thoracolumbar system, as a synonym for a system where the first fiber, the preganglionic fiber, is shorter than the postganglionic fiber. The preganglionic fiber is shorter than the postganglionic fiber. Right? The preganglionic fiber is shorter than the postganglionic fiber on the side of the spinal cord. And so a synonym for the sympathetic nervous system is the thoracolumbar nervous system. So that's one thing. Another thing to look at is look at all the viscera that are innervated here. Right? All of the internal organs that are important for function. Your eyes so that you can see. Your heart so you can pump blood. Your lungs so you can breathe. Your stomach so you can eat. Your pancreas. Your intestines. Your liver. Your adrenal glands. Your reproductive organs. Your bladder. All of the organs that you need to function are getting signals here from the ANS. Right? So when the adrenal gland releases its epinephrine into the blood, the epinephrine is traveling to receptors in all of these organs. It's doing something at distant sites from where it's released, the definition of a hormone. It's doing things to your eye, to the diameter of its pupil. It's doing things to your salivary gland. It's doing things to your heart, to your lung. Right? Think sympathetic man. Right? I'm sweating, I'm fighting, my heart's beating hard, my bronchi are dilated so I can breathe, so I can supply oxygen to my muscles and my heart as I try to avoid being smashed by the heavyweight champ. Right? So, sympathetic nervous system organization. And so, by the way, if you happen to have a drug that you're giving for some other target, maybe you're treating somebody for some kind of mental disorder, and that drug is having an off-site effect that's perhaps affecting sexual performance, making them incompetent or making them underperforming, or maybe it's affecting the heart, causing an arrhythmia, or maybe it's causing bronchoconstriction so the patient's asthmatic and now they're having a bad, serious asthma attack. Right? So while we spend time in this course and talk about a few drugs that you see a lot, and then a lot of drugs that you won't see that much, right? That's ANS. Drugs that you do see may have effects in the ANS that you don't want to have. And so we have to kind of understand the system to understand how to minimize these off-target effects, or to the point that you can minimize them. All right, so again, in sympathetic synapses, just note the location of the synapse. The first ganglia is on the side or close to the spinal cord. So the first fiber is much shorter than that second fiber. This slide is just to remind us that the adrenal medulla is what we would consider a ganglion, a modified sympathetic ganglion. And so that first fiber leaves the CNS and forms a synapse in the adrenal medulla with the chromaffin cell of the adrenal medulla, releasing which neurotransmitter if this is a ganglion? Acetylcholine binding to what kind of receptor on this cell? If it's a postganglionic cell. A nicotinic receptor. Yes? It's like any old ganglion up till here. But there is no second fiber. And so the tissue just releases epinephrine into the blood, which gets carried around to targets and binds to receptors of the alpha and beta varieties. All right, so this is the exception, and we called it the modified sympathetic ganglion. Now, we spent a lot of time earlier today on the board talking about the cholinergic synapse. This slide is talking now about the adrenergic synapse. And so one of the things I'd like us to first talk about is just this right panel, this upper right panel. And so do we see here in this upper right panel, if we look at the bottom of that axon terminus, we have exocytosis of a transmitter that diffuses across the cleft and binds to adrenoceptor. Adrenoceptor is a vague term, right? What does that mean? It means a receptor that binds to a catecholamine, but there are different types of such receptors. There are beta 1s, there are beta 2s, there are alpha 1s, there are alpha 2s, and there's D1s. So which receptor is this adrenoceptor? Adrenoceptor is just a vague term. It covers all of them, and then you need to know more, right? So if we're in the heart, this receptor is beta 1 mostly with a little bit of beta 2. If we're in the bronchiolar smooth muscle, this receptor is mostly beta 2. Right? If we're in the vascular smooth muscle, this receptor is mostly alpha 1. Right? So what is this receptor? What's the consequence of it being activated? Now, if we step over to the left panel and we look at the synthesis of catecholamines, we see something pretty amazing. Right? So all of this stuff in the left panel is happening in the axon terminus of the adrenergic synapse. And so we go from tyrosine to norepinephrine, that multi-step process that looks complicated, but really isn't that complicated. So here we are. We start with this amino acid tyrosine, which, by the way, comes into the axon terminus through a transporter because it's not hydrophobic enough to just be absorbed. So the name of the transporter is called the sodium tyrosine cotransporter, or the sodium tyrosine symporter. Right? And it brings tyrosine into the axon terminus. And so remember tyrosine, we talked a lot about tyrosine, receptor tyrosine kinases. And we said tyrosine is this great residue to be phosphorylated, right? Well, why? Well, we have this para-hydroxy group here, which can act as a phosphoacceptor. Right? So you can make this O-phosphate, double bond O, O minus, right? And you change the whole electrical status of the peptide. But that tyrosine that I'm referring to as a site for phosphorylation is not just a freely floating single amino acid. Rather, it's built into a peptide as one of many amino acids, right? So if you were to look at tyrosine, you've got your amino group, your carboxy group, and peptides go from amino to carboxy, right? So here you'll have your next amino acid, and your next amino acid, and your next amino acid. Here you'll have your next amino acid, and your next amino acid. So in the context of a peptide, tyrosine is not freely floating. But it is a great substrate for kinase. But that's not what I'm talking about here. Here I'm talking about freely floating tyrosine. So this is the tyrosine that the tRNA never picked up. Right? This is the walk-on the football team. Right? This is the person who never got called on to be on the team in gym class. Right? I don't really want to play anyway. Right? Right? But this tyrosine has also an alternate and exciting path. Because this tyrosine will become a catecholamine. It can have all kinds of systemic action. So while that tyrosine may have been down because it wasn't picked up by tRNA, it can be converted to a catecholamine. And so look at what happens. Here's my tyrosine, and maybe I can't draw it. It looks like an amino acid. I know which one it is because it's para-hydroxy tyrosine. But look what happens. It's going to go from this structure, and just look at the change. See where my pointer is? Look at what happens in the first step. That area gets hydroxylated. The enzyme that puts a hydroxy group on a substrate is called a hydroxylase, an enzyme that hydroxylates something. What gets hydroxylated here is tyrosine. The enzyme is called tyrosine hydroxylase. So all I did is put a hydroxy group there. Now I have formed a chemical structure called a catechol. A catechol is this structure. All right, it's a phenyl ring that has two adjacent hydroxy. If I had the hydroxy here, is that a catechol? No. Right? But I have the hydroxy here, so I got a catechol. Catechols are substrates for an enzyme called COMT. COMT can do this. You put a methyl group on one of the hydroxys. COMT stands for catechol O methyl transferase. Right? COMT. Catechol O methyl transferase. Transferase, enzyme that transfers something. Transfers what? A methyl group. Transfers it where? To an oxygen. On what structure? A catechol. When you methylate a catechol, you inactivate it. Okay? So we'll take a break in like 2 minutes or so. But when you methylate a catechol, you inactivate it. So right now, everything I have to say about the things downstream, all these catecholamines, none of them are metabolized by phase 1 or phase 2. None of them go through a P450 reaction. None of them get conjugated. The way they get metabolized is by the action of an enzyme called COMT. And where is COMT? COMT is found in the postsynaptic cell. In the cell, inside. Another enzyme that can break down a structure that contains a catechol needs something else on the catechol to break it down. So let's keep going. Right? So here we've made a catechol. The catechol is called L-dopa. Now, if we look at this structure, we have a catechol and an amine. See the nitrogen here? A catechol and an amine. So we call this a catecholamine. Right? And so when we go from L-dopa to dopamine, the only thing that happens is that this carboxyl group gets taken away. Right? Take me away. Right? Boom, dopamine. Right? So did you see? It's gone. So I've gone from L-dopa to dopamine. A catecholamine. Now, dopamine is unprotected. Right? So if you had a player on your baseball team like Matt Harvey and he was not protected, the Yankees would come in and swoop him up and take him away. Right? But he's protected. He's under contract. But if he was not protected, somebody would come in and swoop him up. So in the world of chemicals and in the saga that goes on in the cell, there's an enzyme in the presynaptic cell called monoamine oxidase. Monoamine means whoa. Oh, my poor pointer. Dr. Lau can't do it. Had him. Well, that'll be a private situation. Right? But monoamine oxidase is an enzyme that cleaves monoamine. So how many amines do you see in dopamine? 1. Right? So it's a monoamine. So monoamine oxidase cleaves catecholamines. And there's a lot of monoamine oxidase up here. So isn't it kind of weird? That stuff's like swimming around. It's waiting to cleave anything that's a catecholamine. But yet you're making dopamine here. So how does that work? Well, the dopamine gets packaged into a vesicle to protect it from degradation. But dopamine can't just get through the vesicle. It comes in through a transport protein called VMAT. And VMAT stands for vesicle monoamine transporter. Vesicle monoamine transporter. Dopamine comes in to the vesicle and it's protected from MAO. And in the vesicle, it gets hydroxylated by an enzyme called dopamine beta hydroxylase. So look at what happens here. So we have our dopamine. The enzyme is called dopamine beta hydroxylase. A hydroxylase is an enzyme that transfers what onto the substrate? Hydroxy into the alpha beta position of dopamine. Dopamine beta hydroxylase. So look at that carbon. Look at what happens to that carbon. That carbon, that carbon, that carbon, boom, hydroxylated to form norepinephrine. Right? So just a few steps from tyrosine, and here we are at this suppressor agent, norepinephrine. Now, norepinephrine is usually the end of the story, unless you're aware which tissue, which gland, the adrenal gland. And in the adrenal gland, there's one more step. So follow my finger. You see that nitrogen? See that nitrogen? See that nitrogen? Boom. What happened to it? Got methylated. What kind of enzyme puts methyl groups onto substrates? Methyltransferase. This one is called an N-methyltransferase. Why is it an N-methyltransferase? The nitrogen was the acceptor of the methyl group. Why is COMT an O-methyltransferase? An oxygen is the acceptor of the methyl group, right? So this is called N-methyltransferase. And it has a fancy name, phenylethanolamine. Now that sounds scary, but if this was an OH, what would it be? CH3, CH2OH would be the ethanol, right? That would be ethanol, right? So this is called ethanolamine because it kind of looks like ethanol, but there's an amine. And this is called a phenyl because it's a phenyl, right? So phenylethanolamine and methyltransferase puts on a methyl group. So do you remember what NOR means in organic chemistry language? NOR means loss of methyl, right? So the difference between epinephrine and norepinephrine is a stinky little methyl group, right? But that stinky little methyl group matters because you never hear of people taking a norepinephrine pen to survive their bee sting, right? So what receptor does that stinky little methyl give you the norepinephrine doesn't have? It's in the bronchiolar smooth muscle. Beta dose. Beta dose. Beta 2. So this gives you some beta 2 selectivity that norepinephrine doesn't have. So with that, let's take a 4-minute break, 5-minute break. We will resume at 2:56 p.m. Okay, so back to our discussion. So what you see on this slide is a blown up description of the adrenergic synapse. And here we see a lot of the elements that I've already mentioned now kind of all together. Let me see if I can use the screen here, pointer. Okay, so if we look way up here, there's our tyrosine, right? And it's coming into the cell through this sodium tyrosine cotransporter, right? It's being hydroxylated to dopa, it's being decarboxylated to dopamine, and it's being put into vesicles through this structure labeled B, but we know that that stands for VMAT, vesicle monoamine transporter. Okay, and the VMAT brings in the dopamine where it gets hydroxylated to norepinephrine. And there it sits waiting for the signal for that voltage-gated calcium channel to open, which is going to happen when the action potential comes down from the cell body, down the axon into the terminus. When that calcium channel opens, we have fusion of the vesicle to the terminus through the interaction of vamps and snaps, and the vesicle pours out its contents to the cleft. Now, again, this happens like a ketchup pack splattering all over the cleft. And so it's messy, right? The norepinephrine gets released in a burst through exocytosis. Some of it diffuses to adrenergic receptors on the target tissue. But in this particular synapse, there's no way to really inactivate the norepinephrine. Like in the cholinergic synapse way back here, right? That acetylcholine gets broken down by an enzyme called acetylcholinesterase, which is present on the surface of the effector tissue. And so there's an enzyme here that breaks this acetylcholine down. It's gone. But in the adrenergic synapse, there is no enzyme tethered to the effector cell membrane that's going to break down norepinephrine like a norepinephrine. There is none. And so what happens is some of the norepinephrine that was released and that stimulated receptors here on the effector tissue also moved towards the presynaptic receptors and affected those receptors. But some of it is being brought back in presynaptically through a transport protein here. So this circled number 1 on the slide is really a transport protein called the norepinephrine transporter. So the norepinephrine transporter is going to allow norepinephrine to be taken back into the cell. This is sometimes called reuptake. Reuptake. Sometimes it's just called uptake. So for my purposes, uptake and reuptake, I'm not going to distinguish between the two, right? But the norepinephrine can be taken back into the axon terminus from which it was released. And when it gets there, what might happen to it if there's MAO floating around all over the cytoplasm of the axon terminus? It might be inactivated. Right? It might be degraded. But the other possibility is that the norepinephrine may be recycled back in through the VMAT into the vesicle. So there's two outcomes of reuptake. One is degradation. The other is recycling, repackaging. You see that? Right? Now, on the other side of things, some of that norepinephrine can be taken into the postsynaptic cell, into the effector tissue. You see this 2 with a circle around it? That's a transporter called the EMAT. EMAT stands for extracellular monoamine transporter. Extracellular monoamine transporter. And it can actually bring the norepinephrine into the cell, where it will be inactivated by COMP plus MAO. Right? So once the COMP touches it, it's no longer active. Once the MAO touches it, it's cleaved. All right, so MAO monoamine oxidants. So these are the biological fates of norepinephrine. It can be released and bind to receptors postsynaptically. It can be released and bind to presynaptic receptors. After it's done its job and it falls off, some of it may just go away by diffusion, but most of it gets reabsorbed either into the presynaptic axon terminus through uptake 1 and the norepinephrine transporter, or into the postsynaptic cell through reuptake or uptake 2 through the extracellular monoamine transporter, where it gets degraded. So when you give a patient catecholamine IV in the hospital, you don't worry about which P450 it's going to be metabolized by, because the way it's inactivated is by reuptake 1 or reuptake 2 and cleavage by MAO or COMP and MAO. Okay? So this one's got a peculiar mechanism of inactivation. So let me talk a little bit about this presynaptic receptor. Okay? So for the most part, that presynaptic receptor that we're going to be concerned about is the alpha-2 receptor in the adrenergic synapse. And that alpha-2 receptor, when stimulated, causes an increase in GI activity, which causes a decrease in cyclic AMP. Okay? So when alpha-2 gets stimulated, it's stimulated to inhibit. And what it inhibits is further release. So this acts as a feedback inhibitor. It says to the cell, stop releasing. Right? It turns off the release of more. Okay, so what happens if alpha-2 receptor gets stimulated? We see drops in norepinephrine release. Less release than we would have had. Right? So, I'll give you an example of an alpha-2 agonist. an alpha-2 agonist like clonidine. Clonidine is a drug that acts by stimulating alpha-2 receptors. So what does it do to norepinephrine release? Less, right? If there's less norepinephrine release, then what happens to the blood vessels? Do they constrict as much? No. What happens to the heart? Does it beat as hard and as fast? No. So what happens to the blood pressure? It goes down. Right? So clonidine is an alpha-2 agonist used to treat hypertension. And it works by decreasing levels of norepinephrine. Okay? All right, so that presynaptic receptor can be important. In the case of clonidine, it's important. Now, let's talk a little bit about drug targets. If we look back at this slide, we see at the very kind of around 2 o'clock here, a drug called metyrosine. Right, metyrosine is an inhibitor. That's what this minus means. Right, it's an inhibitor of an enzyme called tyrosine hydroxylase, which is that enzyme that we need to hydroxylate tyrosine to dopa. So if metyrosine is brought into this system, what happens to levels of norepinephrine? They go down. Now, metyrosine is a drug mostly used experimentally, but can affect release of norepinephrine. The next drug that you see on here is a drug called reserpine. And reserpine is an inhibitor of the VMAT. So if the VMAT is blocked, what happens to dopamine? Does it get packaged? No. So it floats around and it meets our friend MAO and it gets degraded. So what happens to levels of norepinephrine if reserpine is around? They go down, right? Because there's nothing to package and there's not as much coming out. Yes? Right? So reserpine is a very interesting drug. So reserpine comes out in the 1950s. You got a picture, Elvis is rocking the house, right? Top 10, number 1, pound dog, blue suede shoes. And Framingham studies coming out saying that hypertension correlates with bad health outcomes. Right? So hypertension is no good, so we've got to control hypertension. Before Framingham study came out, right, which was a big, humongous epidemiology study, people thought high blood pressure was just like something that happens to you when you get older, and it's part of life. But the Framingham study suggested that if you have high blood pressure, that correlates with disease. Right? Things like stroke, things like cardiovascular disease, atherosclerosis. Right? And so people said, well, let's start to find ways to pharmacologically control blood pressure. And so reserpine was a plant-derived product that was effective at reducing blood pressure because it prevented packaging of dopamine into vesicles. It prevented norepinephrine from being made because there's an enzyme in here called dopamine hydroxylase? Beta, dopamine beta hydroxylase. Right? And so there's less norepinephrine being dumped. And so on the heart, right, less norepinephrine means negative inotropy, means negative chronotropy, means decreased cardiac output. Less norepinephrine on blood vessels means what in terms of peripheral vascular resistance? Right? Normally alpha-1 receptor stimulated to constrict by norepinephrine. You're not making as much norepinephrine, so are you getting as much constriction? No. So peripheral vascular resistance goes down. So what happens to blood pressure if both cardiac output and PVR go down? It goes down. Yes? Right? So reserpine was great because it reduced blood pressure by depleting norepinephrine in the autonomic nervous system. But here's the deal with reserpine. Many people who took it for hypertension started to experience depression. In fact, some people killed themselves. They got so depressed they committed suicide. And so the FDA started looking at this drug like, what is going on with this drug? And so it was soon discovered that reserpine crossed the blood-brain barrier and cause depletion of norepinephrine in the CNS. Now, norepinephrine is one of those transmitters in the brain that if you have normal or high levels, you have a positive feeling about your day. And if norepinephrine levels are low, that correlates with feelings of depression, feelings of sadness, and depressed mood. Some of you may dispense a drug or see a drug dispensed in the pharmacy called venlafaxine. Any of you have seen that one? Right? That one works by blocking the norepinephrine transporter in the brain. And if you block the norepinephrine transporter in the brain, what happens to levels of norepinephrine in the synaptic cleft? They stay high or they accumulate, right? So levels go up. Good for brain in people depressed, bad for the ANS. Because what do high levels of norepinephrine mean in the ANS in terms of effects on the heart? Heart beats harder, heart beats faster. How about on blood vessels? Constriction. So how about blood pressure? Goes up, right? So one of the things about venlafaxine you got to keep your eye on is your patient's blood pressure, is your patient's heart rate, right? There's an arrhythmia liability with that drug. Yes? Makes sense? Right. So you're giving it for a central nervous system function. You want to reduce depression. You want it to have an effect in the CNS. But because of its pharmacology, it's having an effect as well in the ANS, possibly. So keep your eye on heart rate, blood pressure, stuff like that. You can't separate the two. So I love that part. So that's an interesting one. So what would happen if you took reserpine and MAOI? I don't know. Might work. Might prevent it. But MAOIs have a lot of drug-drug interactions and so the answer is nowadays we have other drugs that won't do that. So reserpine is available, like you can get it. It's still out there. It can be prescribed. But it's mostly used now like in research settings, to study depletion of norepinephrine. But that's a good point. So here was a very functionally good drug, but in some patients it became so depressed it was a limiting drug, and it didn't have a long shelf life in terms of how long it was used in the clinic. Right? If we look now down here, and so that worked by inhibiting VMAT, right, the cyclomonoamine transporter. There are some drugs that inhibit the interaction of adrenergic vamps and synapse. So just like Botox did this in the cholinergic synapse, in the adrenergic synapse we have drugs like guanethidine and beryllium, which prevent diffusion and the release. Now these drugs are antihypertensive, right? So antihypertensive. Okay, but they're not really used first line because there's better drugs now. Right? Think about how these work. They don't prevent synthesis, they just prevent fusion. The norepinephrine's already been made, right? So these drugs are useful, so I'm going to say also useful in thyroid storm. Thyroid storm is a bad thing. It is an acute medical emergency of severe hyperthyroidism. So, thyroid is the heart. So something I haven't told you. Thyroid hormone primes the heart to respond to catecholamines. So, if you have a condition where your thyroid is overactive, and most people don't have that. In the U.S., it's more common to have an underactive thyroid, right? You see a lot of prescriptions for thyroid hormone in your pharmacy, right? So that's more common. But there's a type of disease called Graves' disease where your thyroid is overactive. Right? And if you have overactive thyroid, you're at risk for cardiac toxicity because it makes your myocardium respond better to catecholamines. Catecholamines make the heart beat harder and faster, right? So it's said that thyroid hormone primes the heart, right? Makes it more sensitive to catecholamines. So here's a situation of thyroid storm where the patient's thyroid hormone levels are 7 or 10 times higher than they should be. They're in an acute medical emergency. Their heart is palpitating so badly, the sweating profusely, you're in a life-threatening event. So one of the approaches is going to be to block the action of norepinephrine by using beta blockers out in the periphery, like propranolol. Right? Another part of the treatment will involve using a drug like guanethidine or beryllium, which is going to prevent more release of the stuff that's already out there. Because the tissue, instead of responding at this level, is responding at that level. So what's already out there, really, rather than being like this, is being like this. And so the heart's beating harder than it should. So thyroid storm is something we talk about in endocrine drugs a lot because it's a life-threatening emergency. But if there's multiple drugs used to treat it, one is used to block the beta receptor, the beta blocker. The other is used to block release of any more that might come out. And the third is used to block an enzyme called 5'-deiodinase, which is used by the body to make T4 into really active T3. So there's multiple drugs to treat thyroid storm, not just those two, but those two are useful because they prevent extra release of this stuff, which is driving the heart into cardiotoxicity. Okay? So you don't really see these as the first line in a typical hypertensive patient, but you will see them in certain settings. Yeah, so when you use like guanethidine, the vesicles are kind of stagnant, right? They're sitting there indeterminate. They've accumulated lots of norepinephrine, and when the drugs wear off, they're going to dump them, right? So this is kind of hospital setting, carefully monitoring the patient's blood pressure, heart rate, weaning them down off the drug kind of approach. Did that help? Okay. All right, so last bunch of drugs I'll mention in the adrenergic synapse for the moment are one drug of abuse and one drug that's used a lot. So the first is cocaine. Cocaine is an inhibitor of the norepinephrine transporter. And so cocaine is abused for its centrally acting effect, right? It makes people feel euphoric, makes people feel good. There's a song about it by Eric Clapton, right? But my encouragement to you, outside of just being your instructor, is just don't go there. Because you won't be you anymore. You'll be like wanting to be who you were. And you won't be able to get there that easily. Right? So I tell you this because, unfortunately, like where I come from, in Bergen County, there's like been a huge increase in cocaine use. A huge increase in heroin use in high school kids, 16, 17. It's a tragedy because these are the kinds of drugs that you take once or twice and you always want them. And you might always want them for a long time. And so you become a mean person. You treat your wife badly and your kids. You hurt people. You steal. You may kill somebody. You may kill yourself. Right? It's not good to let a substance take you over. So fight it. You got problems, go for help. You got all these people here. We can help you. But don't let a substance take you over. Because you won't be you. Right? I'm under a substance, right? It's damn coffee. Right? It really, I need it, or I'm mean to my wife. It's not good. And I don't know how to delete that. I might re-record this one. But don't let a substance take you over. But how does this one work? So this one comes into the CNS, and it blocks the uptake of norepinephrine. So you're saying, Dr. Bill, you're going between CNS and ANS. I don't get it. Well, it's a nervous system, just like the CNS is. They have very conserved things. They do things similarly. So in the CNS, if you block reuptake of norepinephrine, there's a lot of norepinephrine out there in the cleft. And norepinephrine correlates with euphoria, feeling good, and all of that. Right? But we know the feeling is transient, and it leads to this craving for more. And then there comes a point where you become tolerant, and not only do you want to do it more, you need more of it. And then it just gets worse and worse. So again, please, we'll care about you even if you do it, but it'll be harder for us to get you out of that hole, right? If you start. You just don't. So there's that. So here's the problem. You got like a 25-year-old kid coming in the emergency room, and their blood pressure is like 220 over 170, and they might stroke out on you. Why? Because they took the drug for the CNS effect, but the drug also has an effect in the ANS. And so lots of norepinephrine out there. Lots of norepinephrine to cause your heart to beat fast, cause your blood vessels to constrict, drive your pressure up. All of a sudden, you're 25, you shouldn't have hypertension, and you shouldn't be like that high, but now you are. Right, so no good. You don't want to have a stroke because you overdose on something. No good. Right? Now, the second drug here is a prescription drug, tricyclic antidepressant. So these are the drugs like nortriptyline, amitriptyline, desipramine, ipramine. Have you seen any of those in your pharmacies? Right? So some of you are saying yes. So these drugs work in the CNS. Right? They get in and they're very good at treating depression. They reestablish levels of norepinephrine. Some of them increase levels of serotonin. Some of them increase levels of dopamine. There's complicated pharmacology of these drugs. But they also inhibit the norepinephrine transporter, so they have an effect in the ANS. So if you block reuptake of the norepinephrine in the ANS, heart beats harder, heart beats faster, blood vessels can constrict, blood pressure can go up. So tricyclic antidepressants, you're going to monitor your patient who's taking it for depression for cardiotoxicity, for signs of hypertension, right? For signs of arrhythmia, for signs of rapid pulse. Those are all liabilities that will come on board with the TCA. Very effective in what it does, but it also is going to do something in the ANS, which is not the intended target. Yes? Right? So hopefully I've convinced you that the two systems can actually talk. And another reason why knowing the ANS is important, because while some of the drugs we'll talk about in the next 3 lectures or so, you won't see very much. Many drugs have anticholinergic action that are going to touch on the ANS. And a lot of drugs can affect heart rate, heart rhythm, prolong the QT interval, and do things like this that can affect the ANS. Okay, so cocaine tricyclics are norepinephrine transporter reuptake inhibitors. You may have heard of a very broad class of antidepressant drugs called SSRIs, selective serotonin reuptake inhibitors. They work something similar in the brain. They prevent reuptake of serotonin, more serotonin out there in the cleft. So mood is not just regulated by norepinephrine, it's complex, and there's other transmitters, serotonin, dopamine can be involved. But we do know that norepinephrine levels do matter because drugs like venlafaxine work to help people get over their depression, right? So that's all I'll say about antidepressants, because of course you'll have a whole course on these things in lots of detail at some point in later curriculum. But from an ANS perspective, we have, unfortunately in this case, some toxicities that may happen due to the drugs acting in the ANS as well. Okay, so the adrenergic receptors are listed for us here, and there's nothing terribly surprising or new, other than the fact that there are multiple forms of alphas and multiple forms of betas. And so you see on that list something called the beta 3 receptor, which I really don't talk too much about. And the reason why I don't talk too much about it is because it's mostly found in fat cells. And so the beta 3 receptor is actually a very interesting drug target. People are trying to develop selective beta 3 agonists. Because if you can develop a selective beta 3 agonist, you can cause the fat cell to burn its fat. It becomes skinny. Right? And so the idea there is, can you treat obesity with a drug by causing a fat-burning drug to act at the 3 receptor and not act at the other receptor? And so you can pharmacologically treat obesity. The answer thus far has been no. We haven't really been that lucky because most of the agonists that stimulate beta 3 have to also stimulate beta 1, which also has effects in the blood. So the search continues. Right? Maybe one day there'll be a beta 3 selective agonist used to burn fat, and I'll sign up and make a shake out of it, and we're all good. I got breakfast and my fat burns out. But for the moment, we're going to focus on alpha 1, which is linked to GQ, contraction, 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 contraction of what? Vascular smooth muscle, contraction of glandular smooth muscle. Alpha 2, presynaptic feedback inhibitory receptor. Clonidine is an agonist of. Right? Beta 1, mostly in the heart, some beta 2 in the heart. Beta 2, mostly in the bronchial smooth muscle, but also in some vascular smooth muscle as well. So did you ever see, like blushing? What happens when you blush? Your face gets red. Why does it get red? Because of vasodilation in your face, right? So that vasodilation mediated by beta 2 receptors in the blood vessels that go in, under your skin. Right? So beta 2 receptor on vascular smooth muscle causes vasodilation. Alpha 1 receptor on vascular smooth muscle causes vasoconstriction. So which is it? Well, it's going to depend, but usually at high doses the alpha 1 effects predominate. And vasoconstriction wins. Okay, so I'll show you in Chapter 9 a little bit of that story and the complexity there. Okay, so you're feeling okay with the type of receptor, where you find it, the second messengers, because this is redundant in a way. We've been saying this for the last hour or so. Now, where did these alpha and beta receptors come from anyway? Well, in the 1940s, there was a pharmacologist named Dr. Alquist, and he was located in Europe. And this was really interesting because Europe was totally decimated in the 1940s, right? It was like waking up and saying, why did humanity do this to you? Right? What did we need this for? Right? It's just a bunch of rubble everywhere. Right? So he turned probably to science as a way to cope with all of the horror and tragedy that he saw around him. I didn't know, but that's what I was doing. And so he studied different tissues in the lab. He studied pieces of the aorta from a rat called arterial strips. Right? Unlike the chicken strips you may buy at McDonald's, the arterial strips from the aorta of the rat. He studied bronchial smooth muscle, and he studied heart muscle. And at this time, it was known that there are catecholamines, right? But the receptors for catecholamines weren't very clear. It wasn't well understood. In fact, there were also synthetic catecholamines, of which I is a synthetic catecholamine called isoproterenol. And so, if we look to see what happened in his study, at the very top panel, he looked at the effect of these different catecholamines. 2 natural catecholamines, epinephrine, norepinephrine. 1 synthetic catecholamine, isoproterenol, from low concentration to high concentration. And what he found is that of the 3 catecholamines, epinephrine was the most potent at contracting the arterial strips, followed by norepinephrine, and way down here, at non-physiologic doses, isoproterenol. However, when he did the study in bronchial smooth muscle, the compound which was the least potent in the arterial strips became the most potent in the bronchial smooth muscle. So he argued that there must be 2 types of catecholamine receptors. The alpha type was named after the arterial strips. The beta type was named after the bronchial smooth muscle. And then when he looked at the heart and compared it to the bronchial smooth muscle, he saw something interesting. He saw that whereas in the bronchial smooth muscle, norepinephrine didn't really work well, in the heart, epinephrine and norepinephrine were equally potent to each other. Okay, so isoproterenol is a synthetic catecholamine. It can be used to cause increased heart contraction in someone who has a failing heart. But it's kind of dangerous. It has a narrow therapeutic window because it can push you into an arrhythmia. So usually you want a skilled person working with isoproterenol. So it's very potent in terms of the cardiotoxicity potential. And so is epinephrine, but isoproterenol is even more so. Okay? But it's out there in hospital pharmacies. People use it. Okay? The hospital. But if you look at the natural ligands, epinephrine, norepinephrine, on the heart, very similar effects. But on the bronchial smooth muscle, very different effects. So which is more potent, epinephrine or norepinephrine? A relaxing bronchial smooth muscle. Epinephrine. So why don't you give a norepinephrine pen to your patient that has bee sting allergy? Because it's not going to work. Right? It doesn't have affinity for beta 2. Right? But in terms of beta 1, they're pretty similar in terms of affinity. Right? In terms of effect on alpha receptors, they're pretty close too. Right? But not in terms of beta 2. So anyway, Dr. Alquist and then later Dr. Lanz followed up on these studies, and they came up with subtypes of these receptors. So they went beyond just being alpha arteriole, beta bronchiole or smooth muscle to now alpha 1, alpha 2, beta 1, beta 2, beta 2. Okay? All right, so if you look at this slide, this is showing you something also interesting. It's showing you that there are subtypes of the subtypes. Right? So if we look here on this slide up there at alpha 1, we see alpha 1A, alpha 1B, alpha 1D. Alpha 1C is a rat form, so it's not unreal. Right? But alpha 1A, alpha 1B, alpha 1D, do you see like they differ in terms of these pitchforks? You see those pitchforks? Those pitchforks are like a symbol for glycosylation. So glycosylation is a type of post-translational modification. A change to the protein after it's been translated. So the protein's been made, and it's now been somehow changed. Changed how? By adding a sugar to it. If you add a sugar to a peptide, you make something called a glycoprotein. Right? Part sugar, part protein, glycoprotein. When you add sugar to a protein, you change the microenvironment, because now all of a sudden you bring a lot of water around there. Or a lot of interaction with water, hydrophilic properties. So one drug might prefer one subtype compared to another drug, depending on its chemical property through that. I don't know, you seeing that? You feeling that? So I'm not going to focus on all of the subtypes in a lot of detail, but I will tell you that in the last chapter, chapter 10, we're going to talk about alpha 1 blockers in terms of being non-selective alpha 1 compared to alpha 1 subtype selective. You might say alpha 1A blocker. So when I say non-selective alpha 1 blocker, that seems like it's rocking my world, because what do you mean non-selective alpha 1? You told me alpha 1. Well, there's alpha 1A, there's alpha 1B, there's alpha 1D. So if it's non-selective alpha 1, it means all three types are susceptible to inhibition. If it's alpha 1A selective, it means that at therapeutic doses, only alpha 1A is blocked. You see that? If I say non-selective alpha blocker, now I'm saying it blocks alpha 1, then alpha 2 is just all non-selective. You see that? So I can say non-selective alpha blocker and just say, man, that thing blocks all alpha receptors. I could say alpha 1 selective blocker, which would be like alpha 1A, for example. Or I could say non-selective alpha 1 blocker, which would say that it blocks all subtypes of alpha 1A. So I can see it. Okay? But just follow the term, right? Non-selective alpha 1 means all the subtypes are susceptible to inhibition. If you say alpha 1A selective, only that one is blocked. Okay? And that becomes important because we're going to talk about an adverse effect of alpha blockers called orthostatic intolerance, or postural hypotension. And postural hypotension is a challenge on your body when you go from sitting to standing. So in a few minutes, you're going to go from sitting to standing. And gravity is going to try to pull your blood down, because that's what gravity does. It's going to try to pull you down. Right? But you're going to stand up, and your blood vessels are going to constrict, and it's going to get back to the heart, which is going to boost it and pump it back to your brain. So your brain never deprives of oxygen. If your brain deprives of oxygen, you're in trouble. You're in real big trouble. You ever hear that song, Someone Please Call 911? That song. My wife didn't make this video, but I did it. It's kind of violent, but anyway. It's violent in the sense that someone shot him, and the bullet has pierced his soul. You know what I'm saying? So it's a metaphorical illusion being shot. I had to make up for it, babe. You know what I'm saying? I had to make up for it. But anyway, I don't know what I was talking about. 911, someone please call 911. Oh, orthostatic. So I'm standing up, and the blood is trying to go down, but my blood vessels are constricting. The blood's getting back to my heart. My heart's pumping to my brain. If it couldn't happen, what would happen? I would stand up, and I would get the D word, dizzy, and I might fall down. And if I fall down, where does my blood go? When I'm in the horizontal plane. Is there any resistance to gravity? No, so my brain stays bathed in blood so I can survive. Fainting is actually a survival response. So your brain doesn't get deprived of oxygen. Right? Dogs and cats, quadrupeds, they don't get postural hypotension because blood is on a horizontal plane. So when you give them an alpha blocker, you don't worry about the thing. Right? But when you give an old patient, you know, like a 75-year-old grandma kind of patient who's knitting you a sweater because she loves you and wants you to be happy and not cold at the same time, and she goes to stand up, and if she falls down, it's bad because she can hurt herself. She breaks her hip, man, it's bad. She may survive, but we got these horrible hospital-acquired infections out there that might mess it up, and often does. So anyway, we'll talk about the subtypes in terms of postural hypotension and certain drugs that do it more than others. Now the table, I promised you that I will show it to you, and again, I've mentioned it to you already. It's in Chapter 6. But here's the table of various organs on the leftmost column, so the eye, the heart, blood vessels, so on. Sympathetic stimulation, parasympathetic stimulation, the receptors involved, and the responses that you see when those receptors are stimulated. So, for example, sympathetic activation of beta-2 in bronchiolar smooth muscle relaxes it. So beta-2 agonists like albuterol does what to a patient's ability to breathe? Makes it easier because the bronchi dilate. On the other hand, M3 receptor in the bronchiolar smooth muscle, when stimulated by the parasympathetic nervous system, causes it to contract the bronchi. So some patients may not be able to take a beta-2 agonist as a rescue inhaler because it causes them to have sinus tachycardia because there's some beta-2 receptors in the heart and they're very sensitive to it. So they may take what kind of blocker? A muscarinic blocker. Have you ever seen a drug in the pharmacy like ipratropium or tiotropium? They're muscarinic receptor blockers. They prevent contraction. If you prevent contraction, it's easier to breathe than if you permit contraction, right? So this is the way, hopefully, the table can help you prepare for later topics, right? And so the way I would encourage you to do it is by looking at the opposing responses. The bronchiolar smooth muscle is the easiest. Sympathetic relaxes, parasympathetic contracts. And so maybe that's the way you go about trying to study these opposing responses. And then you kind of notice that some of these only have one and not the other. So the endothelial cells, right? The endothelial cells, where are they? Right? Well, that's an endothelial cell, and that's an endothelial cell, and that's an endothelial cell. And here's the smooth muscle beneath it. And here's the lumen. Right? There's our blood vessel. And so those endothelial cells have M3 receptors on their surface. Acetylcholine binds to them, and they release EDRF, which is also called endothelial derived. Why? It's derived from the endothelial cell. Blank factor. What is the blank? Relaxing. So what happens to the blood vessels? They dilate. So what does acetylcholine do to blood vessels? Dilates them, but not directly. Indirectly. Through EDRF, which is also known as nitric oxide. Right? So there's no sympathetic innervation of the endothelial cells, but you can bet that there's sympathetic innervation of the blood vessels. Right? So this is the table that took me 6 hours the first day, 3 hours the second day, 1 hour the third day. I passed it on the test. I walked out and didn't think about it again until years later. But I'm hoping that you do think about it again, and not years later, but a few weeks later when you get into drugs and disease or get into pharmacotox or whatever your next class is going to be if you go to board. Because a lot of drugs that are acting for other purposes might do something here. Like some drugs can cause you to be impotent, right? So anticholinergic effect can be impotence in male. That's not good if you're trying to, bring in a new one into the world. Now, come on board. Right? You ever hear that song, Fantastic Voyage? You come along and ride on a fantastic voyage. Right? That's life. It's sometimes hard, but it's always fantastic. It's always fantastic because you're here. Think about the chance of you really being here. Like, you could be like a molecule in Jupiter, in the atmosphere. But you're here. You could be like a piece of dust flying into the sun and burning up. But you're here. Right? You could be like a bug. Which might not be that bad, depending which bug you are. But anyway, you're not. The odds. In 2015, why not 800? Why not 25 BC? Why not et tu Bruti? Why didn't you tackle it, keep Caesar alive, right? How is it that? It's amazing. It's like always purposeful. It's always purposeful. So anyway, I would say I can't just put it in your head, but if you put it in your head, you'll be in good shape for drugs that are coming in the next chapters. The way to look at this is what happens when those receptors are stimulated. This is what happens when beta-2 receptor is stimulated. Right? This is what happens when alpha receptor is stimulated. This is what happens when beta receptor is stimulated. By the way, look, there's no parasympathetic innervation of things like the liver, the fat, or the kidney. Think sympathetic man. You're running, right? You're boxing. You're not eating an apple or a piece of fruit. You don't like apples, right? So your liver is releasing sugar. So your muscles can have energy, so you can fight and flight, or fight, or whatever. Okay? So, to the extent you can, try to get through this. And I keep putting it in here. We've seen a few tables that show parts of the big table as we go, and we'll keep seeing that in the next few lectures. Last thing I'll mention in the last few minutes is just that we'll call this the miscellaneous autonomic issues. So think about pre versus postsynaptic receptors. The postsynaptic receptors are the ones in the target tissues. So what are they? Where are they? What are they doing when they're stimulated? And what happens if you block their stimulation? Presynaptic receptors are things like the alpha-2 variety. What do they do when they're stimulated? They stop release. They're feedback inhibitors. Co-localization or co-release of peptides and other transmitters. So here I should pause. So we saw a few minutes ago a big picture of sympathetic and parasympathetic innervation in various tissues. And one of the tissues we saw it going to was in the gut. Right? Your large intestine, your small intestine, your digestive system. And so we know the gut is very interesting because in the vesicles, be they cholinergic or be they adrenergic, well, there's no vesicle here. But be they cholinergic or adrenergic, there's often in the gut other things in those vesicles. Those other things are signaling molecules or peptides. So there is a picture in your book which I haven't shown you, but if you look at it, there's a lot of signaling molecules in the gut that help it move better, peristalsis, or that help it not move as well, which we would call constipation, right? It's not moving. So you see things in the gut, in these vesicles, things like vasoactive intestinal peptides, things like neuropeptide Y, or things like substance P, or sometimes serotonin. You see these other chemicals that are sometimes called non-adrenergic, non-cholinergic. Right? Sometimes they're in there. And so what are they doing? We don't always know what they're doing, but we believe that they somehow modulate the effect on the gut. They have a modulatory role. I'm not going to make a big deal of it, but some textbooks spend a little bit of time on this idea called the enteric nervous system. Enteric meaning the gut. And some books will consider it the third branch of the autonomic nervous system. Okay? For our purposes today, I think we'll just say that, The gut is a special case where sometimes you'll see other transmitters in these vesicles beyond jet, norepinephrine, or acetylcholine, and we'll leave it at that. Your book spends like a whole page on this, but we'll leave it at that for our purpose. Okay? So this has brought us up to the interface of chapter 1, which is